Hi, welcome to our channel of IGNOU audiobooks, Indira Gandhi National Open University, School of Health Sciences, SOHS, Diploma Programmes, Postgraduate Diploma in HIV Medicine, PGDHIVM, MCMM 001 Basics of HIV Infection, Block-1 Epidemiology of HIV, Unit 3 Response to Epidemic, 3.0. Objectives. After going through this unit, you should be able to times describe need for response to HIV/AIDS, times define global response to HIV/AIDS, times describe national response to HIV/AIDS, and times summarize outcomes of global national response. 3.1 Introduction. On 5th June 1981, 5 cases of pneumocystis carinii pneumonia in young, homosexual men in Los Angeles were reported by Centers for Disease Control. At that time, very few suspected that it heralded a pandemic of AIDS. In the hardest-hit countries, the foundations of society, governance, and national security are eroding, stretching safety nets to the breaking point, with social and economic repercussions that will span generations. This crisis demanded a unique and truly global response to bring the resources, political power, and technical capacity of countries to halt and reverse this epidemic. Such a response would have required policymakers to address taboos concerning sexual behavior, drug use, and power, relations between the sexes, poverty, and death. At the end of the 1990s, public health experts identified a number of highly effective interventions to prevent and treat AIDS, TB, and malaria. Knowledge about the scale of epidemics and a deeper understanding of the complex causal links among poverty, development, and disease pushed international issues of public health to the center of the world's development agenda. At the same time, the global community began to appreciate more fully the devastation caused by HIV/AIDS in parts of Africa, the Caribbean, and Asia, and the potential for even greater consequences should the epidemic take root in the world's most populous nations. New life-saving medicines for people living with HIV were priced out of reach for more than 90% of those who most needed them. This fueled a global movement to reduce the cost of essential medicines, backed by an appeal that such commodities be seen as global public goods rather than commercial products. The year 2001 has seen a remarkable convergence of political, scientific, and economic forces, creating major new opportunities for a more intensive global response to the AIDS pandemic. 3.2 Global response to HIV epidemic. 3.2.1 Initial response. During the early years of the epidemic, the World Health Organization, WHO, became a leading organization in the international response to the HIV/AIDS epidemic. WHO played a leading role in helping countries organize national AIDS programs and in developing midterm strategic plans. In 1987, 6 years into the pandemic, the World Health Organization, WHO, established the Global Program on AIDS. This program raised awareness about the pandemic, formulated evidence-based policies, provided technical and financial support to countries, initiated relevant social, behavioral, and biomedical research, promoted participation by non-governmental organizations, and championed the rights of those living with HIV. Among other efforts, the program provided assistance to 2 countries, Uganda and Thailand, that successfully reversed their epidemics. Debt relief is among the important mechanisms being used to try to help African countries mobilize the funds needed to fight HIV/AIDS across the continent. Many of the African countries most affected by the HIV/AIDS epidemic were also among the world's most heavily indebted countries. The idea behind debt relief is that the lending institutions or countries would forgive or cancel existing debts. In exchange, the countries would use the funds they save for HIV/AIDS and other poverty reduction programs. Probably the most important effort is the Heavily Indebted Poor Country (HIP) initiative developed by the World Bank and International Monetary Fund 3.2.2 Establishment of UNAIDS. Despite its achievements, the global program on AIDS was unable to muster the necessary political will in donor and affected countries. United Nations system decided by the mid-1990s that it needed a greatly expanded program. In 1996, the program was replaced by the Joint United Nations Program on HIV/AIDS, UNAIDS, initially EO-sponsored by 6 UN agencies with a mandate to lead an expanded, better coordinated, multi-sectoral global response. Currently, the EO-sponsoring organizations are the International Labour Organization, ILO, Office of the United Nations High Commissioner for Refugees, UNHCR, United Nations Children's Fund, UNICEF, United Nations Development Programme, UNDP, United Nations Education, Scientific and Cultural Organization, UNESCO, United Nations Office on Drugs and Crime, UNOC, United Nations Population Fund, UNFPA, UN Women, World Food Programme, WFP, World Health Organization, WHO, and World Bank. UNAIDS is designed to be the leading advocate for an expanded worldwide response to HIV/AIDS. As such, it is designed to encourage and coordinate action, rather than to function as a direct funding or implementing agency. Later on, 4 key developments inspired a new receptivity to the advocacy of UNAIDS. First, the World Bank became more active in AIDS-related lending. Second, in 2000, the 13th International AIDS Conference in Durban, South Africa, raised global public consciousness about Africa's upward spiraling AIDS-related mortality and the need for accessible, affordable antiretroviral drugs. Around the same time, Brazil reported that its use of antiretroviral drugs had dramatically reduced AIDS-related mortality and hospitalizations, providing hope for other developing countries. Emboldened non-governmental organizations then agitated for the purchase of lower-cost, generic antiretroviral drugs and price reductions for brand-name products, while the Doha Declaration concerning the agreement on the trade-related aspects of intellectual property rights and public health permitted broader access to antiretroviral drugs. Third, politically powerful religious groups, particularly in the United States, that had long been reluctant to support condom distribution and other sex-related prevention programs embraced the need for global treatment, largely in order to reduce the numbers of children being orphaned by AIDS. And fourth, the spread of HIV into Russia, China, and India prompted concern that AIDS could destabilize global political and economic systems beyond sub-Saharan Africa, threatening global security. These developments generated a long-needed enhanced response. 3.2.3 Millennium Development Goals. In 2000, the largest gathering of world leaders at United Nations headquarters in New York adopted the United Nations Millennium Declaration. Declaration, endorsed by 189 countries, committed nations to a new global partnership to reduce extreme poverty, and it set out a series of targets to be reached by 2015. These have become known as the Millennium Development Goals, MDGs. Goal 6 of the MDGs sets out by 2015 to have halted and begun to reverse the spread of HIV, and to have achieved, by 2010, universal access to treatment for HIV for all those who need it. UN Secretary-General Kofi Annan convened the United Nations General Assembly special session on HIV/AIDS, UNGAS, held in New York in June 2001. It was for the first time that a General Assembly meeting was devoted to a health issue. The political leaders from 180 governments adopted a declaration of commitment that set program targets for affected countries and funding levels for donor governments. Heads of state and representatives of governments issued the Declaration of Commitment on HIV/AIDS, acknowledging that the AIDS epidemic constitutes a global emergency and one of the most formidable challenges to human life and dignity. It sets out a series of national targets and global actions to reverse the epidemic. The Declaration of Commitment unanimously adopted at that session included commitments to national planning, prevention targets, including 25% reductions in prevalence among young people, urgent provision of the highest attainable standard of treatment for HIV/AIDS, enacting or strengthening human rights protection for people living with HIV/AIDS, reducing vulnerability to HIV infection, national strategies to support children orphaned by AIDS, dealing with the economic and social impact of AIDS, increasing investment in HIV-related research, including work on vaccines and microbicides, incorporating HIV programs in emergency responses, 3.2.4 targets and commitments, as indicated by UNAIDS, the main targets and commitment for HIV programs, times reducing sexual transmission, times preventing HIV among drug users, times eliminating new HIV infections among children, times increasing access to art, times avoiding TB deaths, times closing resource gap, times eliminating gender inequalities, times eliminating stigma and discrimination, times eliminating travel restrictions, times strengthening HIV integration, 3.2.5 Universal access to HIV/AIDS prevention, treatment and care, 3x5 initiative. On World AIDS Day 2003, WHO and UNAIDS released a detailed and concrete plan to reach the 3x5 target of providing antiretroviral treatment to 3 million people living with AIDS in developing countries and those in transition by the end 2005. This was a vital step towards the ultimate goal of providing universal access to AIDS treatment to all those who need it. Towards universal access, in 2006 governments made a historic commitment at the United Nations to scale up dramatically the AIDS response. In the Political Declaration on HIV/AIDS, 2006, countries committed to provide universal access to HIV prevention, treatment, care and support services to all those in need by 2010. This commitment has as its foundation the Declaration of Commitment on HIV/AIDS, 2001, in which governments first made a series of time-bound commitments to expand their efforts to address HIV. Both of these instruments support achieving the Millennium Development Goals, MDGs, particularly MDG 6, which seeks to halt and reverse the spread of HIV by 2015. Universal access is broadly defined. It does not necessarily mean 100% coverage of all services, but can be seen as a desire to move to a high level of access for the most effective interventions that are equitable, accessible, affordable, comprehensive, and sustainable over the long term. 99 countries have set their own 2010 universal treatment access targets, with most countries aiming for 80% treatment coverage, 3.3 financing the response to HIV/AIDS, 3.3.1 multilateral funding organizations, funding for HIV and AIDS spending in low and middle income countries is distributed by multilateral organizations, which obtain their funding from a number of national governments. The largest such body is the Global Fund to Fight AIDS, TB and Malaria. Around 61% of Global Fund funding is spent on HIV and AIDS. The World Bank is the second largest multilateral donor to the HIV and AIDS response in developing countries and is one of 8 co-sponsors of UNAIDS. By the end of 2006, it had funded 75 projects to prevent, treat and reduce the impact of HIV and AIDS. The World Bank tends to look at the economic aspects of the epidemic, especially the negative effects that HIV and AIDS can have on a country's economy. 3.3.1.1 World Bank. The World Bank pioneered global HIV/AIDS financing early in the emergency and remains committed to achieving Millennium Development Goal 6 to halt by 2015 and begin to reverse the spread of HIV/AIDS through prevention, care, treatment, and mitigation services for those affected by HIV/AIDS. The World Bank offers long-term financial and specialized technical support and knowledge to countries for effective prevention of new HIV infections, care and treatment, for people living with HIV/AIDS. And alleviation of social and economic consequences for affected communities. The bank provides sustained funding for HIV/AIDS programs and supports countries to do better for less through improved efficiency, effectiveness, and sustainability of national AIDS responses. The bank specifically supports analytical work in 6 related areas: I. Allocative efficiency, 2. Program technical efficiency, 3. Effectiveness studies, 4. Financing and sustainability studies, National strategic planning, and 6. Financing, grants and loans. Since 1989, bank financing for HIV/AIDS has totaled nearly $4.6 billion. As of FY12, bank financing for HIV/AIDS stands at $1.8 billion. The bank works with stakeholders to improve evidence related to HIV prevention and engages in key sectors such as education, transport, energy, and infrastructure. As one of 11 co-sponsors of UNAIDS, the bank helps SHR the global response to HIV/AIDS in partnership with governments, non-governmental NGOs, other agencies and foundations, and the private sector. 3.3.1. To Global Fund to Fight AIDS, Tuberculosis, and Malaria, Leaders Around the World in Development, Economics, Public Health and the Community of Non-Governmental Organizations, Representatives for People Living with HIV, the World Health Organization, the World B-Tilde, UNAIDS, and bilateral donors sought ways to increase global spending on public health to change the course of these diseases. Times leaders of G8 countries acknowledged this need for resources in their 2000 meeting in Okinawa, Japan, as did African leaders at a summit held in Abuja, Nigeria in April 2001. Times in Abuja, former United Nations Secretary-General Kofi Annan called for the creation of a global fund to channel additional resources. Times a United Nations General Assembly special session on AIDS in June 2001 concluded with a commitment to create such a fund, which the G8 endorsed and helped finance at their meeting in Genoa in July 2001. Times a transitional working group was formed to develop a framework for how the Global Fund would be structured and operate on an ongoing basis. Times the Global Fund is a unique, public-private partnership and international financing institution dedicated to attracting and disbursing additional resources to prevent and treat HIV and AIDS, TB and malaria. This partnership between governments, civil society, the private sector and affected communities represents an innovative approach to international health financing. The Global Fund's model is based on the concepts of country ownership and performance-based funding, which means that people in countries implement their own programs based on their priorities, and the Global Fund provides financing on the condition that verifiable results are achieved. Times since its creation in 2002. The Global Fund has become the main financer of programs to fight AIDS, TB and malaria, with approved funding of $22.6 billion for more than 1,000 programs in 150 countries. To date, programs supported by the Global Fund have provided AIDS treatment for 3.3 million people, antituberculosis treatment for 8.6 million people, and 230 million insecticide-treated nets for the prevention of malaria. The Global Fund works in close collaboration with other bilateral and multilateral organizations to supplement existing efforts in dealing with the 3 diseases. 3.3.2 Bilateral funding organizations. Bilateral funding monies provided directly by national governments to other countries is also an important source of support for HIV/AIDS efforts. The American government donates a substantial amount of money for the HIV/AIDS epidemic through United States Agency for International Development, USAID, the Centers for Disease Control and Prevention, CDC, the Department of Defense, and the Department of Labor. In January 2003, the United States announced the creation of PBPFAR, the President's Emergency Plan for AIDS Relief, through which it pledged $15 billion over a period of 5 years to prevention, treatment, and care, with a focus on 15 countries that are home to 80% of the people requiring treatment. PEPFAR was renewed in July 2008 with the intention of spending $48 billion from 2009 to 2013 on programs to tackle HIV and AIDS as well as tuberculosis and malaria. PEPFAR is an umbrella for all the existing HIV and AIDS-related funding being provided by the American government, including the HIV-related funding that was previously distributed through the U.S. Agency for International Development, USAID. The Department for International Development, DFID, is the UK government's department for managing Britain's distribution of foreign aid. Though it provides funding for a large range of projects, addressing the global AIDS epidemic is among its principal goals. A new plan for HIV and AIDS support was announced in 2008 with the emphasis on health systems strengthening rather than on high and AIDS-specific ally. 7 DFID is the world's second biggest bilateral donor for HIV and AIDS, and is also a major donor to the Global Fund. Other bilateral donors are British government's Department for International Development, DFID, the Australian Agency for International Development, AUSAID, Canadian International Development Agency, CIDA, 3.3 private sector funding organizations. There are a very large number of private sector organizations involved in the response to HIV and AIDS, including corporate donors, individual philanthropists, religious groups, charities and non-governmental organizations, NGOs. These organizations vary in size, from small groups such as local churches to large contributors such as the Bill and Melinda Gates Foundation and corporate donors. Overall, the private sector is by far the smallest of the four main sources of funding for the global HIV and AIDS response, accounting for around 4% of spending, while the size of its funds make it small in comparison to multilateral organizations. The Bill and Melinda Gates Foundation has nonetheless given very large sums of money and support to the global fight against HIV and AIDS. It has also made large contributions to HIV and AIDS vaccine and microbicides research. The William J. Clinton Foundation, founded by the former American President, Bill Clinton, is another private organization with HIV and AIDS as one of its main concerns. The foundation addresses the inequalities in access to health care in the developing world and in particular aims to improve access to antiretroviral treatment for developing countries. 3.3.4 Domestic HIV and AIDS spending. Domestic spending by people and their governments accounts for a significant part of the global response to HIV and AIDS. Money from domestic sources tends to be much more sustainable than bilateral and multilateral donations, and is therefore an extremely valuable source of funding for combating the epidemic. However, the amount of domestic spending varies considerably from country to country, and many governments have not yet made HIV a priority in their budget allocations. In many developed countries, with the notable exception of America, most HIV-related costs are covered by the government through public health programs, such as the National Health Service in the UK. In some less well-resourced countries, governments only finance between 25 and 50% of costs, with the remaining money having to be covered by the patients themselves. 3.4 Results of response. Progress towards the vision of reversing the epidemic of HIV/AIDS is accelerating dramatically in several areas. In 2011, more than 8 million people living with HIV in low and middle-income countries were receiving antiretroviral therapy, up from 6.6 million people in 2010, for an increase of more than 20%. This puts the international community on track to reach the goal of 15 million people with HIV receiving treatment by 2015, as set out by the 2011 Political Declaration on HIV and AIDS and unanimously adopted by United Nations member states. Mortality is also declining. In Africa, AIDS-related deaths have fallen from 1.8 million in 2005 to 1.2 million today. The trajectory of new infections has been broken, with a worldwide decline of 20% since 2001. New infections among children have declined dramatically for the second year in a row. Of the estimated 1.5 million pregnant women living with HIV in low and middle-income countries in 2011, 57% received effective antiretroviral drugs to prevent transmission of HIV to their children, up from 48% in 2010. With the momentum being generated by the global plan towards the elimination of new HIV infections among children by 2015 and keeping their mothers alive, the international community has set a strong course to achieve an AIDS-free generation. During the past year, many countries, especially the burgeoning economies of Africa, have seized the opportunity to demonstrate their ownership of their national AIDS response and share responsibility for the global response. They are transcending the outdated donor-recipient paradigm and using the AIDS response to create a new and more sustainable agenda for global health and development. This agenda of shared responsibility is taking firm hold. We are seeing the evidence as countries step up to increase domestic investment in HIV, sharing the burden and the accountability for results. Sharing the burden, however, is more than investment. It means collectively tackling the political, institutional, and structural barriers that impede progress. It means ensuring that resources are going where they can have the greatest impact, HIV being integrated with reproductive health, maternal and child health, tuberculosis, women's cancers, support for people with disabilities, and other movements. 3.5 Strategic directions, vision, and goals. At the same time, significant challenges remain. The latest estimates from UNAIDS shows that 34 million people were living with HIV at the end of 2010, and nearly 30 million have died from AIDS-related causes over the past 30 years. While the rate of new HIV infections has declined globally, the total number of HIV infections remains high, at about 7,000 per day. In addition, gender inequalities remain a major barrier to effective HIV responses. HIV is the leading cause of death among women of reproductive age, and more than a quarter of all new global HIV infections are among young women between the ages of 15 and 24. Despite expanded access to antiretroviral therapy, a major treatment gap remains. At the end of 2011, 7.5 million people who were eligible for treatment did not have access. Treatment access for children is lower than for adults. Only 28% of eligible children were receiving antiretroviral therapy in 2009, compared to 36%. Coverage for people of all ages. UNAIDS advocates following strategy for next 5 years. 3.5.1 Revolutionize HIV prevention. More than 7,000 people are newly infected with inventory every day. A revolution in prevention politics, policies, and practices is critically needed. This can be achieved by fostering political incentives for commitment and catalyzing transformative social movements regarding sexuality, drug use, and HIV education for all. Led by people living with HIV and affected communities, women and young people, it is also critical to target epidemic hotspots, particularly in megacities, and to ensure equitable access to high-quality, cost-effective HIV prevention programs that include rapid adoption of scientific breakthroughs. Vision: to get to zero new infections. Goals for 2015: times sexual transmission of HIV reduced by half, including among young people, men who have sex with men, and transmission in the context of sex work, times vertical transmission of HIV eliminated, and AIDS-related maternal mortality reduced by half, times all new HIV infections prevented among people who use drugs. 3.5 To catalyze the next phase of treatment, care and support. A total of 1.8 million people died from AIDS-related causes in 2010. Access to treatment for all who need it can come about through simpler, more affordable, and more effective drug regimens and delivery systems. Greater links between antiretroviral therapy services and primary health, maternal and child health, TB, and sexual and reproductive health services will further reduce costs and contribute to greater efficiencies. Enhanced capacity for rapid registration will increase access to medicines, as will countries' abilities to make use of TRIPS flexibilities. Nutritional support and social protection services must be strengthened for people living with and affected by HIV, including orphans and vulnerable children, through the use of social and cash transfers and the expansion of social insurance schemes. Vision to get to zero AIDS-related deaths. Goals for 2015 times universal access to antiretroviral therapy for people living with HIV who are eligible for treatment, times TB deaths among people living with HIV reduced by half, times people living with HIV and households affected by HIV are addressed in all national social protection strategies and have access to essential care and support. 3.5.3 Advance human rights and gender equality for the HIV response, social and legal environments that fail to protect against stigma and discrimination, or to facilitate access to HIV programs continue to block universal access. Countries must make greater efforts to realize and protect HIV-related human rights, including the rights of women and girls, to implement protective legal environments for people living with HIV and populations at higher risk of HIV infection, and to ensure HIV coverage for the most underserved and vulnerable communities. People living with and at higher risk of HIV should know their HIV-related rights and be supported to mobilize around them. Much greater investment should be made to address the intersections between HIV vulnerability, gender inequality, and violence against women and girls. Vision to get to zero discrimination. Goals for 2015 times countries with punitive laws and practices around HIV transmission. Sex, work, drug use, or homosexuality that block effective responses reduced by half, times HIV-related restrictions on entry, stay and residence eliminated in half of the countries that have such restrictions, times HIV-specific needs of women and girls are addressed in at least half of all national HIV responses, times zero tolerance for gender-based violence. 3.6 National response. HIV epidemic in India is concentrated in nature. The HIV prevalence among the high-risk groups, i.e., female sex workers, injecting drug users, men who have sex with men, and transgender is about 20 times higher than the general population. Based on HIV Sentinel surveillance 2008-9, it is estimated that 23.9 lakh people are infected with HIV in India, of which 39% are female and 3.5% are children. The estimates highlight an overall reduction in adult HIV prevalence and HIV incidence, new infections, in India. Adult HIV prevalence at national level has declined from 0.41% in 2000 to 0.31% in 2009. The estimated number of new annual HIV infections has declined by more than 50% over the past decade, from 2.7 lakh new infections in 2000 to 1.2 lakh in 2009. India's initial response to the HIV/AIDS challenge was in the form of setting up an AIDS task force by the Indian Council of Medical Research (ICMR) and a National AIDS Committee (NAC) headed by the Secretary, Ministry of Health. In 1990, a medium-term plan, MTP 1990 to 1992, was launched in 4 states, namely Tamil Nadu, Maharashtra, West Bengal and Manipur, and 4 metropolitan cities, namely Chennai, Kolkata, Mumbai and Delhi. The MTP facilitated targeted IEC campaigns, establishment of surveillance system and safe blood supply, NAC 1, 1992 to 1999. In 1992, the government launched the first National AIDS Control Program, NACPI, and demonstrated its commitment to combat the disease. NACPI was implemented during 1992 to 1999 with an objective to slow down the spread of MV infections so as to reduce morbidity, mortality, and impact of AIDS in the country. To strengthen the management capacity, a National AIDS Control Board, NAC, was constituted and an autonomous National AIDS Control Organization, NACO, was set up to implement the project. The key outcomes of the project included capacity development at the state level in the form of setting up State AIDS Society, SACS, in 25 states and 7 UTs, a well-functioning blood safety program aimed at reducing HIV transmission through blood, expansion of HIV sentinel surveillance system, collaboration with non-government organizations on prevention interventions, intensified communication campaigns, improved public awareness, creation and dissemination of National HIV Testing Policy, NAC 11, 1999 to 2006. In November 1999, the second National AIDS Control Project, NAC 2, was launched. Based on the experience gained in Tamil Nadu and a few other states, along with the evolving trends of the HIV/AIDS epidemic, the focus shifted from raising awareness to changing behavior, decentralization of program, implementation at the state level, and greater involvement of NGOs. The policy and strategic shift was reflected in the two key objectives of NAC 2, times to reduce the spread of HIV infection in India, times to increase India's capacity to respond to HIV/AIDS on a long-term basis. The aim was to keep HIV seroprevalence, I.E. below 5% of the adult population, in high prevalence states, 2. Below 3% in states where the prevalence was moderate, and 3. Below 1% in the remaining states where the epidemic was at a nascent stage. Policy initiatives taken during NAC 2 include adoption of National AIDS Prevention and Control Policy, 2002, National Blood Policy, a strategy for greater involvement of people with HIV/AIDS, GIPA, launching of the National Rural Health Mission, launching of National Adolescent Education Program, provision of antiretroviral treatment, ART, formation of an interministerial group for mainstreaming, and setting up of the National Council on AIDS, chaired by the Prime Minister, NAC 3, 2007 to 2012, drawing from the experiences and the lessons learned from Phase I and 11, India developed the third National AIDS Program Implementation Plan, 2007. 2012, improved understanding of the complex HIV epidemic in India has enabled substantial changes to be made in policy frameworks and approaches of the NAC. Focus shifted from raising awareness to behavior change, from a national response to a decentralized response, and an increasing engagement of NGOs and networks of people living with HIV/AIDS. The National AIDS Prevention and Control Policy and the National Council on AIDS, NCA, chaired by the Prime Minister, provide policy guidelines and political leadership to the response. India is currently in process of implementing the fourth phase of National AIDS Control Program Phase 4. We will discuss about NAC in detail in subsequent sections of this unit. of Block-1 Course National AIDS Control Program 3.7 Summary. The global response to AIDS has achieved significant results since the first case was reported 30 years ago, with a record number of people having access to treatment and rates of new HIV infections falling by nearly 25%. Now 3 decades on, more and more people have access to treatment. Infections are declining and greater numbers of pregnant women living with HIV are keeping their babies free of infection. About 8 million people were receiving antiretroviral therapy in low and middle-income countries at the end of 2011. The rate of new HIV infections fell by more than 50% in India and by more than 35% in South Africa. Both countries have the largest number of people living with HIV on their continents. with access to treatment, AIDS has moved from what was effectively a death sentence to a chronic disease. Antiretroviral therapy is a bigger game changer than ever before. It not only stops people from dying, but also prevents the transmission of HIV to women, men, and children. At the same time, significant challenges remain. The latest estimates from UNAIDS shows that 34 million people were living with HIV at the end of 2010, and nearly 30 million have died from AIDS-related causes over the past 30 years, while the rate of new HIV infections has declined globally. The total number of HIV infections remains high, at about 7,000 per day. In addition, gender inequalities remain a major barrier to effective HIV responses. HIV is the leading cause of death among women of reproductive age, and more than a quarter of all new global HIV-1 infections are among young women between the ages of 15 and 24. Despite expanded access to antiretroviral therapy, a major treatment gap remains. At the end of 2011, 7.5 million people who were eligible for treatment did not have access. Thank you. Subscribe to our channel for more updates, and we will see you with the next chapter.